Now, as to the main announcement for this morning, or other announcement for this morning, it relates to healthcare reform in Minnesota. We're very proud of our healthcare delivery system and our healthcare in the state of Minnesota by most measures. It continues to be nation leading as it relates to measures of quality and effectiveness. There's just a few examples of that. Congressional Quarterly Press again named Minnesota the healthiest state in the nation for 2009 recently, earlier this year. The annual United Healthcare ranking of Minnesotans regularly ranks us either number 1 or 2 in the nation in terms of the healthiest nation, healthiest people in the country. There's another measurement called Commonwealth Fund's State Scorecard that recently came out. They take a broader measurement of healthcare systems and health across states, including not just measures of the health of the population, but broader measures of healthcare access and quality and cost and healthy lives and equity and other measures. Under the Commonwealth Fund State Scorecard, Minnesota recently moved up from 9th place to 4th place, and so demonstrating additional progress in that regard. As well as Minnesota has done in this area, there's certainly more work to be done. If we're going to be nation leading, we need to continue to improve and transform our healthcare system and our health delivery system in Minnesota. There's a lot of work to do in that regard. One of the main concerns that we have as individuals, as families, as businesses, and as governmental units across Minnesota is the affordability of healthcare. It is in many respects a runaway train. It is what is straining family budgets and business budgets and government budgets to the point where it's clear that we cannot continue on the trajectory that we're on and expect to reasonably fund the programs that are available through the federal government, through the state government, through other local units of government and through businesses and for families. So it's with that in mind today that we offer 3 important initiatives. This will be part of a series of initiatives that our administration will be offering to the legislature to consider for the upcoming 2010 legislative session. And we think this one is really very important to sustain a commitment to Minnesotans to be able to afford health care, in this case, both in the private sector and in the public sector. Let me give you just 3 initiatives that we have, and I'll introduce our commissioners to make some comments as well and take your questions. As you know, we have a cost crisis in American healthcare as measured by people's inability to afford healthcare in the private market. The premiums in Minnesota for private market healthcare are slightly above the national average for individual coverage and significantly above the national average for family coverage. The Kaiser Family Foundation recently reported that premiums for family insurance in Minnesota are a good 6 to 7% higher than the national average. And there are many places across the country that offer insurance products, health insurance products that are as good as Minnesota products at a more affordable price. So we think there is value now and in the long haul to open up the marketplace for Minnesotans to be able to purchase health insurance products from other states. This is currently prohibited under Minnesota law. We're going to ask the legislature to change that law so Minnesotans can go into the national healthcare marketplace and purchase their healthcare from a variety of states, from a variety of vendors, and use that as a way to get more competition, more choice, and hopefully more affordability and better quality in the healthcare delivery system. Minnesota has wonderful healthcare providers and healthcare HMOs and related entities, but the fact of the matter is 3 entities control about 80% of the market in Minnesota's insurance or coverage market. That is not enough competition to be robust, to offer enough challenge to entities and to the marketplace to give them enough incentive to, I think, provide a better product and provide more cost savings. And so we want to open up the marketplace, but we don't want to do that without some significant commitment, without commitment to protect consumers from fraud or abuse or inadequate insurance products. So the only products that would be able to be sold to Minnesotans would be those that meet the following criteria. Number 1, the state insurance regulator where the company is domiciled would have to be accredited by the National Association of Insurance Commissioners. Number 2, the insurance company would have to have a certificate of authority to operate in Minnesota. Number 3, the regulator in the state of domicile would have to review and approve the policy forms. Number 4, the insurance company would have to agree to abide by Minnesota claims practices. So if there was an issue or a concern or a dispute, it would be resolved according to Minnesota law and Minnesota procedure. Number 5, the insurance company would have to agree to abide by Minnesota's structure for fees and taxes as it relates to products. And then lastly, we also want the companies to the initial phase of this that would be offering insurance products in Minnesota to be those from the top 20 states in terms of quality, effectiveness, price, and consumer protection as deemed by the Minnesota Department of Commerce. They would do a review, rank the states across the country in terms of those kinds of considerations, and at least in the initial phase of this, Minnesotans would be able to choose from the top 20 states by those measurements. We believe that would be more than sufficient to open up competition, drive improvement, drive change within the insurance market for Minnesotans to save money on their health care insurance. We also think a second phase of this would be to have Minnesota lead a national effort to create a compact amongst and between states to do what we've done in life insurance. Commissioner Wilson and his team were part of the leadership structure for starting a national compact for life insurance where states would mutually agree on the standards and quality assurance measures and consumer protection measures and content of life insurance to be offered across the country. If it was approved by the compact entity, then that product is available for sale in all of the compact states. And there are 33 states that have joined the compact. Minnesota was an early leader on that compact. It provides, first of all, more choice and more marketplace competition for consumers, but it also offers more ease of market access for products. And so you don't have to go to 31 different states to get it approved 31 different times. You can have it approved once by the compact, and it provides economies of scale and efficiency for the individual, for the entities providing and offering the insurance product. So that's point number 1 in the reform. Point number 2 is we have an absolute cost crisis, as you know, in our publicly subsidized healthcare programs. These are good and important programs, but the cost of them is far outrunning any ability to reasonably pay for them. We have a private economy now that isn't growing at all. If we can get back to the point of a 2 or 3% GDP growth, I think people would think that's a reasonable progress for our economy, and yet we have certain aspects of government growing 3, 4, 5 times or more faster than that hoped for rate of growth in the economy. So we have programs like MinnsotaCare, like MA or Medical Assistance in Minnesota, which is our term for Medicaid, that are growing 20 to 30% a budget cycle in terms of the cost of the program. The insurance premiums within those programs are also growing on a biennial basis, approaching those amounts. There is no way that we can keep up with those increases with the revenues that are projected for Minnesota and for most of the rest of the nation in the near and intermediate future. So these programs must be reformed. They cannot be sustained on their current cost trajectory. They cannot be sustained on their current cost platform. So we want to take some proven practices that have been really quite incredibly effective in the private market and in the markets that we've worked with our state employees, and bring those concepts into the public programs, specifically in MinnsotaCare and Medical Assistance. First of all, as it relates to MinnsotaCare, currently there are no deductibles or copays in that program. It's first dollar coverage, and so individuals are not required to select a primary care clinic or even a network of clinics. They have first dollar coverage from the time they walk in the door, which is quite unlike how most Minnesotans or most Americans have to deal with their health care insurance. There should at least be some copays or deductibles in that program. In the case of the medical assistant program, there are very minimal copays. It's $1 or $2. It's understandably low because this is a challenged population economically, so we don't want to make them so high. But what we do want to do is change the construct from just there's no responsibility for what healthcare clinic that the individuals in these programs choose, that there is no accountability for whether you choose one that is effective in terms of cost management or whether you choose one that's effective in terms of quality. So we want to use the program that we have used so effectively called Minnesota Advantage, take those same concepts, namely rank providers by both cost and quality, and then make that information available to the individuals in these programs and their advocates, and then give financial incentives or rewards for using the system wisely. So just like Minnesota Advantage, we would say to the population that we serve through these programs, you can choose a clinic or a primary care network, but if you choose one that is high in cost and low in quality, you're going to pay more. Or you get less of a benefit, as you'll see in just a moment as I describe. If you choose one that is high in quality and more efficient, you'll get a bigger benefit. And the benefit comes in this form. We will have the EBT card, a benefit card, that will store on it an amount of money that will depend on whether you pick a high tier or low tier clinic. You will be able to then use the cash equivalent on that EBT card for benefits that would otherwise be beyond the benefit set of MinnesotaCare or MA. I think that would be a significant incentive to choose more wisely. In the Minnesota Advantage program, and we offered a similar construct for our state employees, 90% of state employees have migrated to a higher quality, more efficient clinics, thereby saving a substantial amount of money for the state of Minnesota and for the employees and their families. In that program, in 3 of the last 5 years, the premium increases have been 0%. I mean, it's astoundingly good. And in the other 2 years during that 5-year period, they have been substantially below market averages. The third reform deals with MinnesotaCare to develop a more modern MinnesotaCare product. As I mentioned earlier, the premium increases experienced by the MinnesotaCare program are approaching 30% of biennium. They're going up about 12 to 13% a year now. If you compound that over 2 years, it's approaching 30% of biennium. There is no reasonable way for the state of Minnesota or any other entity to keep up with those kinds of premium increases. And again, the program must be restructured while maintaining a commitment to quality. We think that the way to do that is to ask those individuals in the MinnesotaCare program who are above the new cutoff that will be debated in Washington, D.C. There's going to be in the health care bill a commitment at 133% of federal poverty guidelines or below to get certain federal benefits. But in Minnesota, we currently go well beyond that in a number of programs, including MinnesotaCare. So you can qualify for MinnesotaCare all the way up to 250% of federal poverty guidelines if you're a individual, or up to 275 if you're a family, parents with children. So what we're proposing today is between the new kind of federal cutoff, 133%, and the level that's available to serve Minnesotans for MinnesotaCare all the way up to 275%. For people who are in that increment of need and eligibility, we want to create a high deductible plan, give a benefit for the cash benefit for the deductible on an EBT card that individuals will be able to use. They'll have the cash equivalent of the amount of money on the card. They'll be able to use that as they go to procure health care services up to the amount of deductible. Then after that, their insurance will kick in. This is a program that we think will incentivize, again, individuals, for at least for the first dollars that they're spending in this program, to use it very wisely. Because if the money runs out prematurely or unwisely, then there may be a gap that falls in between that and when insurance kicks in. So there'll be a significant incentive to migrate to more efficient procedures, to use the system more wisely. And again, currently there's no requirement in MinnesotaCare that they even pick a primary care clinic, much less have it tiered around cost and quality effectiveness. So we believe that this proposal will accomplish that. All 3 of these combined move Minnesota in a direction to a more affordable healthcare system, move in a direction of making sure we have some reasonable cost containment as it relates to government programs that are really out of control in terms of their ability, for our ability to pay for them going forward. And it also maintains assurances around quality and better health care for the people that we're serving. With that, I'll turn it over to Cal Ludeman, who's the Commissioner of Health and Human Services, to make some comments, and then we'll ask Glenn Wilson, the Commissioner of Department of Commerce, to make some comments, and we'll be happy to take your questions. Cal?
Thank you, Governor. Cal Ludeman, Commissioner of Human Services. The last 2 items that the Governor talked about for public programs are powerful changes. The most significant change in what is called medical assistance that would be proposed by any state of the nation. But it is unique to Minnesota because we would have the data that is now being collected through the 2008 reform, healthcare reform, that would allow us to use these peer grouping information sources to be able to make this tiered arrangement for a price-sensitive system. We oftentimes on reform forget to talk about MA. This is where 550,000 Minnesotans are covered. These are disabled, elderly, or low-income individuals in Minnesota. That's a lot of Minnesotans. That's 12 or 13% of the marketplace that needs to find innovation for these improvements. The cost savings could be substantial, although we're not doing this for any budget purpose for this current biennium. The future savings have to start to show up in MA as well. Because of the timelines that the governor said, whether it's the new obligations from the federal government for Medicaid expenditures or even state obligations, these will be hard to catch up unless we get ourselves at least to trend line increases or potentially, hopefully, even below. It also is good for the providers. The new mandate here is this attachment of MA patients to a primary care clinic. We really are concerned about the health and functional status of people on MA. We have and do care about disparities, or what are called sometimes inequities in the system. There's proof positive in many studies that we would make great progress in these patients if we could make sure that our patients attach themselves by their choice to a primary care clinic. By attachment, I mean this is the door that they go in to receive health care services. It is also good for the provider to make sure that they understand who these patients are and have some sense of care coordination for those patients. Simply the right medical health care reform issue as well. So we're not driven simply by financial considerations. The other one about modernizing MinnesotaCare. We are on a trajectory, as the governor said, that is very pressuring the healthcare access fund to a large degree, and we won't start to find new product design within MinnesotaCare for at least the adults in MinnesotaCare, and affect children's coverage in any way. We will also get to a place very quickly where that healthcare access fund will achieve a quicker deficit situation. So we have to find new designs for that to be sensible. We believe that MinnesotaCare clients and customers and insurance holders, coverage holders, are as able as anyone else for HSA market design that is unfold in Minnesota. Minnesota has more HSA compliant plans in the private market than any other state. And so MinnesotaCare is following along with that design and believing that we can also increase effectiveness. If you combine the tiered plan, Mr. Governor, hopefully I've given some explanation to you, and this new design, the customer of MinnesotaCare will have a highly efficient, high quality primary care clinic where they would receive most of their health care and meet most of their health care needs in a very efficient and we think affordable manner in Minnesota.
Thanks.
Well, thank you, Governor. I think the Governor did an outstanding job of outlining the proposal. But one of the things, too, working with Cal as chairman of the state healthcare cabinet, one of the things that we've developed there is the ability to have better transparency on pricing and outcomes. This is one step additional to broaden out in the consumer's arena the opportunity to look for different pricing and more variety in product availability. So again, we think that this will help not only look at in a different way, broadening the options that people have to reduce healthcare costs. From the Commerce Department's perspective, it will be our responsibility to identify those states that meet the solvency and the consumer protection requirements of the state of Minnesota, so that absolutely nothing's lost, but the market is broadened. And so I think this will be a good thing overall for the state and help reduce the overall cost. Thank you.
Thank you. Two other footnotes of discussion as it relates to the financial savings or efficiency that can be realized by ranking providers by cost and quality and then asking individuals to consider migrating to higher quality, more efficient providers. Deloitte Touche did a study around these concepts recently, and they said that up to 5% of total program costs could be saved by this so-called tiering or ranking of providers by itself. Now we have a more conservative internal estimate that says it may be closer to 2%, but basically the range of costs that could be realized, not just in terms of premium increases, but in terms of the total cost of the program, could be as much as 2 to 5% on that change alone. Just the simple act of ranking providers by cost and quality and incentivizing people to migrate to the better providers. And then also this concept of choosing a primary care clinic, another phrase for that that's in vogue these days is medical home, both in the Minnesota reform legislation in 2008 and much of the medical reform legislation that's talked about nationally, the concept of encouraging people to use medical home so you have at least a starting point for continuity of care, record keeping, so you don't have to restart records, don't have to restart test histories, you don't have to restart what's been done before. You have a more coordinated, more efficient approach to healthcare. We believe will make an additional significant difference in these programs on top of that 2 to 5% that I just mentioned in total program cost. So with that, we'll be happy to take your question.
Governor, could we start with drilling down a little bit on the cost? When you say 5% of the total program cost, how much would this be for a family? How much savings for monthly premiums for a family if they migrate in borders of the world?
Well, you just got to break it down into categories, Pat, because the first category is the private insurance purchasing. So this is not, the ability to buy across state lines is the first initiative. And again, the Kaiser Family Foundation indicates that Minnesota's coverage for a family is about 6 to 7% higher than the national average. Now, there's other studies that give you a little higher number, some give you a little lower number, but if you believe the Kaiser number, by opening up the national marketplace, even to the national average, you could save perhaps 6 or 7% or more, depending on your appetite for benefits. And we think the consumer protections that I outlined would more than guarantee the fact that it's a good and solid product for the person purchasing it. Now, getting into the two that relate to public subsidies, publicly subsidized programs, the individuals who are in MinnesotaCare or Medical Assistance who would get the EBT card would get an additional benefit. In other words, if you're in that program now, not the third program I'm talking about, I'm just talking about the individuals who are generally in MinnesotaCare and Medical Assistance, if you choose a medical home and you choose a higher quality, more efficient provider, you will get an additional benefit on a cash card that you can then, or EBT card, that you can then go out and use for certain things that wouldn't normally be in your benefit set. So for example, prescription eyeglasses aren't covered in the current benefit set. You can use the cash value on your card to deal with your prescription eyeglass issue. Another example would be over-the-counter prescription, not over-the-counter medicines that are not prescription medicines. They're currently not covered in those programs, but we would open up the EBT card to be used for those kinds of purchases. So in the second proposal, you would actually get an additional benefit if you're willing to do what we're asking, which is to choose a medical home, and you'll get more of a benefit if you choose a more efficient, lower cost clinic or medical home. If you choose one that's low in quality and high in cost, you may not get any additional benefit. So that's on top of what you would already get. On the third program, you would have your insurance landscape change from what is currently walking in the door, having first dollar coverage, and this is the MinnesotaCare, the modern MinnesotaCare program. You would have now some deductibles and copays, but the deductibles and copays would be managed through a lump sum amount on an EBT card that if you manage well, you could save money and roll it over from year to year and accumulate additional money. If you manage it poorly, then you may find yourself having less. You may find yourself paying more out of pocket until the insurance kicks in.
And they are paying more in co-pays and deductibles, however.
Well, they are going to pay.
Because they'll be paying out of their own pocket.
They're going to pay some co-pays and deductibles, but the point is the cash amount on the card should cover all or most of that if they use it wisely.
Can you handicap the likelihood that the buying insurance across state lines will pass this legislature? It's been tried before and failed. But secondarily, wouldn't it blow up the systems of nonprofit health insurance in Minnesota that's allowed for some of the cooperation that used to be seen in New Jersey?
Well, a couple of things. I think as to the first question, I think it's a new era as we discuss healthcare reform. So the opposition, particularly on the other side of the aisle as it relates to cross-state purchasing of health insurance, may be less than it was, say, 5 or 10 years ago, because I think people hopefully are now more open-minded about healthcare reform and marketplace choice and competition as a way to drive quality and to save money. So my hope is that the legislature would look at this anew rather than just rejecting it out of hand, particularly considering the consumer protections that we brought to bear. Secondly, as to Minnesota's nonprofit status, remember that the only nonprofits in Minnesota are the groups that are structured as HMOs. They all have for-profit insurance arms, and the truth of the matter is they've been migrating the bulk of their business or much of their business to their for-profit insurance arms, and that seems to be the direction of the future. But the point is, whether you're an HMO or whether you're a for-profit entity, you should have to compete. And if you're providing a product that is higher in cost and less in quality, the marketplace should hold you to account for that. And so I don't think it's too much to ask our Minnesota providers, our Minnesota insurers, our Minnesota HMOs to compare themselves to the rest of the nation and compete.
Did you do any of this on your own, or was everything that went legislative approval?
The latter.
Have you talked to legislators about this yet?
Some legislators, but again, these are concepts that I think are part of a unfolding debate about the future of healthcare in Minnesota and across the country. This is part of trying to get ready for the 2010 session, which starts in February. So we want to announce these initiatives this fall and early winter, so legislators have a chance to kick the tires and think about it, and so they're ready to hopefully act and make some decisions when we get here in February.
Governor, this may be a question for Commissioner Ludeman, but on the subsidized, on the public health plans, do we know what percentage of these people on medical assistance currently go to preventive care or primary care physician, or do they get their care in ERs? I know a friend of mine is applying for medical assistance for the first time this week, and she only did this because they found cancer on her tongue. And so I'm wondering how many people are introduced to this system through a hospitalization rather than just wanting to have
That's a great question. But just as it relates to the medical home, you're not required in the current program to even choose a medical home. You can just have your care be as uncoordinated as you like, which is quite contrary to most of the consensus surrounding healthcare reform in the country, at least on that point on both sides of the aisle, about the importance of having just a medical home where you can have your care coordinated and your records tracked and things like that. Kevin, maybe you want to add to that?
That was a good question. Most in MA are not found that way, or do not find MA that way. Most of it is determination of disability through either the state or the SSI process through the Federal Social Security Administration, or dual eligibles, which we call people that are over 65 and also poor and eligible for Medicaid co-spending. And people who are enrolled in what are called the Minnesota Family Investment Program, or FAIR program, are also, they and their families are also eligible for MA. Most of them do not come through that door, emergency door or a high level diagnosis. But if they have no coverage, then obviously they say, what are my options? And what we're trying to do is make sure that option also is included, not only dealing with that emergency or that high-end procedure, probably possibly a life-changing event, but also dedicate themselves toward it and attach themselves to the primary care for the long haul.
And on the tier of providers, do the people considered in the outcast or the high-cost, low-efficiency providers, do they have a chance to move into the higher tiers?
Well, they do. With the state employee plan, for example, they do have an ability to do whatever they have to do, and they ask what it is that they have to do to get themselves into a more favorable tier. I didn't say outcast, I understand what you mean, but if they're in a higher tier arrangement, they have an opportunity to change whatever their business design is to make themselves attractive.
Who determines the quality and price rankings?
We have, I mentioned that we're using the two that we would be using. This would be effective for the planning year, calendar year 2011. This would be using the September 2010 peer grouping information that the Department of Health has contracted for analysis of all clinics in Minnesota.
So is that a state government ranking?
Who does the calculation, the ranking? Who does the work?
Well, I think it's being done in the state of Maine right now is actually with a successful vendor on an RFP through the Department of Health. So the Department of Health will be publishing these peer groupings in September of 2002. An alternative or a proxy for that would simply use the state employee plan, but that would not be necessarily subject to what we would be looking for MA patients, but it would certainly be a very successful proxy as well.
Governor, with regards to the EBT cards, how much money would be put on that card if somebody on medical assistance or MinnesotaCare decides to go to a more competitive plan? How much money are you talking about?
Well, again, there's three components to this proposal. You're asking about the second and third one?
Yes, correct.
In the second one, which is just the bonus, it doesn't take anything away, it's just a bonus that you get for selecting a more efficient and higher quality medical home. I think to be meaningful, we want that to be, $100 or more, so they can actually get something for it. We haven't put the actual amount out there. On the third one, which is now we're going to create a deductible system in MinnesotaCare for those people above 133 up to 275. That's going to have to be a more significant amount of money to make sure that we have an incentive to, first of all, enough money to cover the bulk of the deductibles and co-pays, and also the incentive to be able to roll over some of it from year to year as a way to be wise about how you use it. Underlying all of this is this principle, that individuals and purchasers have to have some incentive to use money wisely, and we want to create incentives for them to migrate their decision-making towards better quality providers and more efficient providers. The current system is a Wild West system where individuals have really no incentive as to how they use it, as to cost or quality, and the costs that we have from the state and from the government are running out of control. So we've got these publicly subsidized health insurance programs that we have to use.
Governor, we should take some.
Also on the phone line. Operator, if there's any calls on the phone line, we'll be happy to take it. Hello? Any others in the room? Operator, if there are any, you can just interrupt us and we'll come back to you.
Governor,
Okay, great.
is there one?
All right, Jeremy.
No, the caps would stay the change. The most significant cap is the inpatient $10,000 hospital cap. That would remain.
And again, for MinnesotaCare, the premiums are going up now. They were going up about 10% a year. They're now going up 12 or 13% a year. If you run that out over a biennium and compound it a little bit, it's approaching 30% a biennium, or a budget cycle increases in premium costs. That needs to be slowed down.
Governor, the U.S. Senate Finance Committee today is passing a healthcare reform bill. Is it a coincidence that you're out here announcing this today? And number two, if some type of reform passes, does this fold easily into that, whatever reform it needs to take?
Well, it is actually a coincidence that we had planned this some time ago. We didn't know that the vote in the Senate committee would take place today. Actually, from my standpoint, it's less than ideal. All focus is on that as opposed to this. But beyond that, it depends on what they finally pass. We don't know that yet. There's a lot of attention today on the so-called Walkus bill. That has to be merged with yet another bill coming out of the Senate Health Committee. There's a whole House bill. It's got to go to the Conference Committee. So who knows, what that eventually looks like in the end. As you know, I don't like it in its current form. But there is one aspect of what's in the Walkus bill, as I understand it, that may very well help what we're talking about today. That appears to be some encouragement or authorization for a group of states to have a compact around interstate purchasing of health insurance. If they actually leave that provision in the bill, or leave it in a form that is not top-down, the federal government telling us how to do it, but they allow us and authorize us to cooperatively and voluntarily join with other states to have a purchasing cooperative, that would fit very nicely into point 1 of this release.
Whether or
We
not
actually
this,
moved that by amendment prior to today.
Okay, never mind what I just said. That would be nice. They had an earlier version. All right,
well,
never mind.
if some form of this passes, however, and we pass some of these proposals here in Minnesota, would you support having Minnesotans opt out of the federal reform plan?
You know, Pat, we've looked at the ability to do that legally and practically, and you know, I don't think there is a easy way for Minnesota to do that, and I don't think we want to make any decisions about our participation in the reform until we see what it is. And it's got a long ways to go. They're not close to having a final package.
In concept?
Well, in concept, I don't like it, but that's different from saying we have the ability to opt out or whether we will opt out.
Is that something that you've said before, that the states would look at opting out, and states don't like the federal healthcare plan?
All right, so you follow these things closely, so you know what I've said in that regard. But what I did say is there is something called the 10th Amendment that speaks to states' rights and the ability for states to chart their own course and have authority within certain matters. But what I also said is legally, it looks like any ability or opportunity for the states to reject something that the federal government does under the sovereignty clause is, you know, very limited. So it's not a matter of seceding, or it's not a matter of suing them. It's a matter of just raising the issue philosophically, and it's a matter of public policy to make sure that people who make the decisions are mindful of the fact that not everything needs to be or should be decided in Washington, D.C. So that's what I've said.
Governor, with regards to allowing citizens to go out of state by another policy, how many other states allow their citizens to do that?
None. We would be the first.
When you put all these together, I take it that you don't have a cost estimate or cost for how much it would cost the state or save the state.
We do, yeah. And item number 1, we believe would save Minnesotans money. Now, these are folks in the private market buying insurance, so it wouldn't be savings to the state, but it would save them some money, we believe, and provide more competition and choice. As to item number 2,
You don't know how much.
I do.
For number 1.
Well, for number 1, well, we're 6 to 7% higher than the national average, so you can make some assumptions on
You
that.
think it would automatically drop 6 or 7% immediately? That way.
Well, what you would be able to do is, instead of having people just have the Minnesota choices, which is primarily 3 choices, and frankly, the 3 choices have kind of melded into not a ton of difference, but some difference. So you would open up the marketplace, and for the people who explore that, we believe, you know, even if you went to the national average, there would be a 6 to 7% savings.
But that's just individual families. You're not saying
Or small
everybody's for business.
What
You're not
are
saying everybody's going to buy from Mississippi or wherever right away.
Well, remember now, it's only the top 20, and they would be free to do that. They wouldn't be required to do it.
So you don't have an estimate of how many would go by across state lines.
No, but I think we do not have a specific number. On the second one, of the total cost of the program, just on the tiering or the ranking feature alone, Deloitte says up to 5%. Again, we have a much more conservative estimate internally at 2%, but 2 to 5% of the total program cost. And then the third one,
Do you have a $50 figure for that?
yeah, at 5%, that would be $80 million a year. A year. Goes to right. Cal, do you want to add something? Let's see how it is. Cal saying it's $100 million a year. Yeah, sorry about that. 100 million. At 5%. 2%.
And that's savings. That includes the extra money you put on the EBT. That's included in this figure.
No, if any money, we'd have to take the EBT money out of the savings that we invest. So gross, it would be up to 80 million, up to 100 million.
What is this? I thought the healthcare reform already had
And then on the last one, the third one, which is the HSA model for certain people within MinnesotaCare, we don't have a specific number, but we know from our HSA experience and from our Minnesota Advantage experience, it's a powerful tool to control costs. In MinnesotaCare, it's essentially evaporated premium increases for 3 to 5 years in the low market for the other 2. And in our HSA market, Minnesota has the highest percentage use in the marketplace of HSAs at about 9.5% of the market, and the studies of that show that they yield significant savings.
And the extra money you put on EBT cards would fall short of the savings. I mean, the savings there'd be more savings than money you put on, extra money you put on EBT.
Yes.
I thought the tiering was already sort of included in the healthcare reform act. How is this?
You know, under current law, there's not requirement for MinnesotaCare and MA for medical home or tiering.
There's only one more question,
All right, anybody else?
Governor, just from a philosophical standpoint, there's been a lot made in the national healthcare debate about how much government direction there is in some of these changes. If the government would be involved in the rankings that drive these incentive programs, where does that fit on the spectrum?
Well, on the first one, Brian, we're opening up the marketplace and creating more competition, more consumer empowerment, more choice, hopefully better quality and better price. On the second and third one, these are programs that the government, meaning the state, is already paying for entirely. So it's not like we're creating a new government entity. This is a program that already exists that we're paying for entirely, and we want to bring pay for performance measurements and considerations into that system instead of just paying blindly for random acts of medical care. All right. All right. Thank you.
So